Good morning, everyone, and welcome to the McLean County Chamber of Commerce June 9th Member Ed. This Member Ed is on the virus, the vaccine, and the vision of a return to normal. Today, we're sitting down with Dr. Kevin Garner from Chestnut Family Health Center, please excuse me, to discuss the COVID-19 vaccination and some reopening strategies for consideration, as well as to address any questions that folks might have. Before we dive into today's presentation and topic, I just wanted to recognize our June video resource library sponsor, which is Health Alliance. By sponsoring our educational programs, the Chamber is able to provide our member eds and town halls to our membership for free of charge. So again, we'd like to thank our June video resource library sponsor, Health Alliance. All of our member ed presentations can be found on our social media platforms. Today, we are presenting via Zoom, but also streaming live to our chamber chat, closed Facebook group. You can always find those presentations there. But we also have all of our presentations out on our video resource library at mcleancochamber.org. The video resource library can be found under Member Resources tab from the website. So make sure to check that out. Again, we would like to thank all of our video resource library sponsors. With their generous donations, we are able to make these chats available to everyone. So I am going to stop sharing this screen for a second. Please excuse me as I transition. We are going to transition over to Dr. Garner now, and he is going to present to us today about the vaccination. And so before we do that, I just wanted to make sure that folks are aware, if you do have any questions, you can drop those in the chat function on Zoom, or if you're joining us from Facebook, you can throw those in the comment section on the Facebook chat. So just wanted to make sure folks are aware of that. And so Dr. Garner, welcome. Thank you for joining us today. As we go through the slides today, just let me know when you want me to move to the next one, and I will be happy to advance that.
Alrighty, great.
The floor is yours. Thank you so much.
Great, good morning, thank you. You have the first slide up with Chestnut on there?
I do, yes. Chestnut line of service lines.
All right, great. So I'm Kevin Garner. I am a primary care physician. I trained at University of Illinois and then in St. Louis to get my internal medicine certification. I'm also board certified in hospice. I've been practicing for about 33 years now, and I've done hospital medicine, office medicine, nursing home medicine, now a medical director. So I work now with Chestnut. I've been a contracted physician with them for over 20 years and have been their medical director for a little over a year. Chestnut started back in 1973 with substance use disorder treatment. I was in the 8th grade about that time, and they branched off into the other treatment categories you see. And I mainly work in the primary care category, but address medical issues in all of the other categories as well. Chestnut's pretty big. They have 9 locations throughout the state, employ over 700 people, and they really do a great job. I wouldn't have joined them after working with them as a contractor for 21 years if I didn't think they did great work. So that's our advertisement. So let's move on to the next slide. So we're going to try to talk about the SARS-CoV-2 or COVID-19 pandemic in 15 minutes or 30 slides or less. COVID-19 and SARS-CoV-2 are pretty much interchangeable terms. SARS-CoV-2 is the virus. The COVID-19 is the illness. So we're going to talk about the virus itself, a little about the history of the virus, a little bit about vaccination and treatment, and then where do we go from here? Visions of what the new normal might be. Next slide. So COVID-19 is caused by a virus that's known as a coronavirus. The virus got its name because when it's looked at in cross-section under an electron microscope, it looks like a crown. The virus family includes viruses that cause the common cold, otherwise known as rhinitis, bronchitis, and viral pneumonia. And most coronaviruses live only in humans and are only transmitted from humans to humans. However, some coronaviruses also infect animals. Occasionally, some of those mammalian or animal coronaviruses will mutate so that they can also infect humans. And this happened a few years ago in, next slide, 2003. There was an illness called the severe acute respiratory syndrome that turns out was caused by a coronavirus that was in a mammal that jumped into humans and caused fairly severe infection. It actually was less infectious than the COVID-19 virus, but much more severe symptoms occurred: severe flu-like illness, pneumonia, respiratory failure, and then multiple organ failure. The mortality rate for that virus was about 10%. In other words, if you got infected, there was a 1 in 10 chance you were going to die. Mortality estimates for COVID-19 are about 2%. So you can see the big difference there. The little guy that, next slide, the little guy that was thought to carry this virus that mutated was called the mask palm civet. You see him there. It looks like a large cat. That creature is indigenous to China and India, thus the start in China. And then it's also found in other areas of Southeast Asia. I had never heard of it until we started researching the history of the coronavirus. And there was also some indication that the horseshoe bat was involved in transmitting the SARS virus as well. So SARS was fairly severe, but not nearly as bad as COVID-19. Worldwide, only 8,098 people had documented illness, and there were only 774 deaths worldwide that were attributed to SARS. Next slide. Once SARS settled down, things were quiet for a while. Then in 2012, out in Jordan, in the Arabian Peninsula, another virus emerged, the Middle Eastern Respiratory Syndrome virus. This virus affected mainly the Arabian Peninsula, but eventually spread to 27 other countries in Asia and India. It again was less infectious than the COVID-19 virus, but mortality rate was amazingly high, 35%. So your odds of dying if you got this virus were about 1 in 3. Fortunately, there were only 858 known deaths worldwide, and only two U.S. citizens got MERS. Both of these were healthcare workers who had been working in Saudi Arabia. Again, there was no specific treatment for MERS, just like SARS. Care was mainly supportive. They threw different drugs at the viruses, but nothing really seemed to work. And next slide, please. Sorry, so here we go. So here we go. The primary animal host for MERS was the dromedary camel. Not found in our part of the world, thank goodness. Otherwise, things might have gotten bad over here as well. Next slide. So what did we learn from SARS and MERS? We learned that quarantining, social distancing, and masking were very effective at containing the infection. Since these viruses are spread only by close contact with infected individuals, the measures worked very well, and the epidemics died out fairly quickly. However, even though these diseases were contained, those viruses are still lurking in the animal population, and they continue to be only 2 or 3 mutations away from causing another epidemic or even a pandemic like COVID. And you can imagine if one of these viruses were to become more infectious, the death rate would be devastating, would be tremendous. Next slide. So again, things quieted down for a few years, and then out of Wuhan, China, Wuhan province in China, SARS-CoV-2 emerged. Again, the COVID-19 virus, SARS-CoV-2, is much more easily passed from person to person via respiratory droplets, either saliva or nasal secretions, when you're coughing or talking or sneezing or singing. And without masks, people who are infected but asymptomatic, no symptoms at all, only infect about 0.7%, less than 1% of people they come in contact with. Once symptoms develop, infectivity is much higher. So everybody who's infected infects at least 2 to 5 other people, depending on which study you look at. So you see the virus spreads fairly readily and quickly. Sorry. There we go. So what caused this fire? Where did it come from? That's a bit controversial. We're not sure, but it might have something to do with this creature and open markets, but nobody is willing to commit to that at this point. Next slide. And it should be on the slide with the heading SARS-CoV-2 and 174 million cases worldwide.
Yes. Okay.
So there have been about 174 million documented cases of COVID-19 worldwide and about 3.74 million deaths, which comes out to a death rate of about 2%. Again, that may be an overestimate because we don't catch all the cases, obviously. In the US, there have been about 33.4 million cases with only 598,000 deaths. US healthcare worker deaths has been about 3,000 frontline workers. That includes ambulance workers, emergency room workers, and then nurses, doctors, physicians assistants, respiratory therapists, all who were working on the front line, so to speak. If the SARS virus had been as fatal, the SARS-CoV-2 virus, COVID-19, had been as fatal or as deadly as MERS, instead of 598,000 deaths in the US, we would have had 11.7 million people die. You see, we rolled the dice and got lucky, actually, that we rolled a 2% instead of a 35% on the genetic mutation. Next slide. So mitigation, how do we keep it from spreading? Well, you got to stay away from respiratory droplets. Droplets for travel up to 6 feet with just talking. With sneezing or coughing or even singing, they travel 2 to 3 times further, at least. Masks do reduce droplet spread. So it is important to mask to reduce spread of the virus. It's also important to cover up while coughing or sneezing, even if you're wearing a mask. With that high pressure, the virus or respiratory droplets are going to be forced out around the mask, around, up, over, below. So it's very important to cover up and also maintain social distance, even if you're masked. Next slide. So what's the SARS-CoV-2 virus look like? What's the COVID-19 virus look like? Well, it's a tiny RNA virus. It's only about at 1 nanometer. That's 10 to the -9 meters in diameter. Can be seen only with an electron microscope. It's covered in protein. And again, the proteins that stick out give it the corona or crown-like appearance. The protein is stuck into lipid membranes. Lipid is a fatty, oily substance. And then the RNA on the inside is also covered in protein called a nucleocapsid protein. All of these proteins can be targets for potential therapy, but right now therapies have concentrated more on the spike protein the vaccination has. Next slide. So how does the virus cause infection? Well, those spike proteins bind to something on human cells called the ACE2 protein. There's actually another protein also that needs to be present called TMPRSS2 that helps modify the spike. Once the spike binds to ACE2, then the cell membrane of the human cell wraps around the virus and envelops it, takes it inside. Then the virus releases its RNA inside the cytoplasm of the cell and co-ops the cell protein and DNA production machinery. The cell's RNA replicates itself over and over and over. It makes more cell membrane proteins, and those cell membrane proteins are implanted in something called the endoplasmic reticulum and the Golgi apparatus of the cell. Those structures then spit out viral particles that then do the reverse of the entry. It combines with the cell membrane, and the cell membrane then spits it out. Once it's out in body fluids, it can either infect other cells and damage more cells, or it can be, if it's in the respiratory tract or GI tract, it can be excreted into the environment, either as respiratory droplets or in the stool. Actually, there have been cases documented in China of viral transmission via droplets from or aerosol from sewage pipes that were leaking a bit. One apartment that housed coronavirus or COVID-19 infected individuals shared sewer pipes with the apartment below, and all of the individuals in the apartment below actually became infected as well. They tested the aerosol from around the sewer pipes, and sure enough, there was COVID-19 virus there. So it can be transmitted not only by respiratory secretions, but also by gastrointestinal secretions. Okay. Next slide. So what happens when you're infected by COVID-19 virus? The infection causes direct damage to the cells by taking over the cell machinery, filling the cells up with virus, causing lysosomes to envelop viruses and burst, releasing destructive enzymes inside the cell, so the cells die. The cells that are most affected by direct infection are the ones that are most rich in the ACE2 and TMPRSS2 proteins that are on the cell surface. These are the lungs, the heart, the kidneys, and the liver, as well as the GI tract. Once cells are infected, the body reacts with an inflammatory reaction, and for some reason, the inflammatory reaction to COVID-19 is overly zealous and doesn't just kill the virus, but it causes an almost autoimmune response where the inflammation spreads throughout the body, damages vital organs, and causes pain in the bone and joints, causes foggy brain, encephalopathy as it's called. And then in the last stage, when the inflammation is intense, blood clotting is triggered. And once blood clotting is triggered, patients get strokes, heart attacks, blood clots in the lungs, blood clots in the legs, kidney failure, liver failure. And this leads to the syndrome known as multi-organ failure syndrome. And that is almost invariably fatal. Very few people bounce back from that. I've seen way too many people in intensive care go through that. It's a very miserable condition to go through. All right, so how do we treat this virus? We do have treatments, and things are looking up because we're finding more and more treatments and more targets to treat. So if you or a family member, loved one, friend are infected but not hospitalized, and you're in a high-risk group, if you're elderly, have heart disease, lung disease, diabetes, or some sort of immune suppression or cancer, then you should probably consider getting an injection of monoclonal antibodies. That the monoclonal antibodies in this situation have been shown to reduce the progression of COVID-19 to severe illness. So it may keep you out of the hospital, and more importantly, keep you out of intensive care, and even more importantly, keep you alive. Again, we don't have mortality data on this situation yet. We do have data that shows that disease progression is prevented by monoclonal antibodies. And it's actually a cocktail of two different antibodies. If you're, next slide, please. If you're infected and ill enough to be hospitalized, first thing to do is to get started on enoxaparin, which is a blood thinner to reduce your risk of blood clots. If you're requiring supplemental oxygen, then you should be treated with, if you're not, ask for it, dexamethasone. Dexamethasone is the only drug available that has definite mortality benefit in COVID-19. It's an anti-inflammatory steroid and has been shown to reduce mortality, death, shown to reduce death by as much as 33%, which is amazing. It's just a steroid. All it does is reduce inflammation, and that goes to show the important role that overzealous inflammatory response plays in the COVID-19 illness. Secondly, if you're hospitalized and on oxygen, you should receive remdesivir. Remdesivir is a molecule that fakes the virus into incorporating it into the RNA that's produced inside the cell. And when it does that, it blocks production of further RNA. So it basically tricks the virus. It's a decoy drug. It shows some reduction in length and severity of illness, but there's no proven mortality benefit yet. So it's always used in combination with dexamethasone to get both the reduction in length of illness and the mortality benefit. If you happen to be intolerant to or allergic to dexamethasone or other steroids, there's a drug called baricitinib that stops the inflammatory reaction at a different site. Not as effective as steroids, but still beneficial. If you continue to deteriorate in spite of those drugs, then there's one more drug called tocilizumab. And that drug is given to people who are having increasing oxygen requirements and has been shown to reduce ICU admission and severity of illness. So we see we've got a cocktail of medications that are available and somewhat effective and reduce mortality by up to 33%, which is much better than we had for SARS or MERS. Next slide. So even more important than treatment is prevention. And the first line of prevention, of course, is mitigation with masking and social distancing, but even more effective is vaccination. If you look back in history, the greatest gains in longevity were not due to drugs or medical miracles, miracle surgeries, transplants. Actually, vaccines prolong life more than any other medical innovation, starting with the polio vaccine. So the SARS-CoV-2 or COVID-19 mRNA vaccines, how are they made? What are they? Well, they're little fragments of viral messenger RNA. These fragments code for the spike protein. They're injected with a needle into the muscle cells in the arm. That mRNA then instructs the cells to make spike protein. That spike protein is expressed on the muscle cells and released into the body fluids, and that causes an immune reaction. Our immune system makes antibodies against the spike. The antibodies then bind to the spikes, not only that the human cells make, but it also binds to any spike proteins on viruses that enter the body. When that happens, the virus can't use the spike proteins to bind to human cells and enter the human cells, so infection is aborted or prevented. And the viruses just float harmlessly through and are excreted out, either coughed up in the respiratory system or go out through the GI tract, and the person goes along happy and uninfected. Next slide. So after the mRNA vaccines came out from Pfizer and Moderna, Janssen and Johnson & Johnson came along with their version of the vaccine This vaccine used a damaged adenovirus that can't replicate. They loaded up the virus with fragments of messenger RNA from COVID-19, did the same process, inject the damaged viruses in the muscle of the arm. The virus then enters the cell and releases the COVID-19 RNA. The RNA instructs the cells to make spike protein. Once again, the immune system reacts to the spike protein, makes antibodies. Those antibodies bind to the spike on any COVID-19 virus that enters the body. The virus, once more, can't get inside the cells and take over the cell machinery and reproduce, and therefore infection is again prevented. Next slide. And this one came out kind of small, but it's an overview of the vaccines that are available. As we mentioned, there's the Pfizer vaccine that was approved first in late 2019, and Moderna vaccine, both mRNA vaccines. And then there's the Janssen or Johnson & Johnson vaccine that's the disabled adenovirus. Yeah. Next slide, please. Okay, so the vaccines aren't risk-free. Common complications with vaccines or common side effects include some pain and swelling in the arm at the injection site. You see that with pretty much any vaccine. Swollen lymph nodes can occur usually in the armpit or axilla. Low-grade fever, body aches, headache, and brain fog, or kind of trouble with executive function and forgetfulness, etc., can occur after vaccination. Usually this passes within 2 to 3 days. And treatment is just rest, fluids, Tylenol or NSAIDs, ibuprofen or naproxen, and you're good to go in 2 to 3 days. If you get anything worse than that, you should call your primary doctor, of course, or if you're having severe symptoms, go to the emergency department, but that's very rare, very rare. These vaccines have been very well tolerated. Now, there have been reports of more rare complications. Most recently, the Johnson & Johnson adenovirus vaccine was briefly taken off the market because of vaccine-induced thrombotic thrombocytopenia. That's a disorder that has includes blood clotting and low platelet counts. Platelets are blood elements that help stop bleeding. So people with this would clot and also
Dr. Garner, I think we lost you there for a second. Can others hear Dr. Gardner?
No, he's frozen.
That's okay. That's what I'm seeing too. Just wanted to make sure. Oh, looks like he just left, and hopefully we'll be re-logging back in. Thanks you guys for our patience. Technology is wonderful when it works with us and not against us. So please hold while we get Dr. Garner back online. Thank you again so much. I apologize for the technical delay, but we will get started here back up momentarily. I know Terry did ask if the slides would be available to everyone. I will ask Dr. Garner if he's willing to share those. We are recording the session today, and so that will be available for later distribution, but I'll see if we can include the slides and send those out to folks who have joined us on Zoom.
Am I back?
You are.
Okay. So what did you last hear?
I think we last heard we were still on the rare vaccine complications. and talking about the blood clotting with low platelets, and moving in kind of to the brain, lung, and heart legs bullet point.
Okay. So we didn't miss too much. Sorry, let me try to get my screen back here. There we go. All right. So as I mentioned, the vaccine-induced thrombotic thrombocytopenia is a clotting disorder. Antibodies are produced to something called platelet factor 4. So it's an autoimmune reaction. Platelets drop and blood clots form. After blood clots form, patients can bleed. And again, this occurs mainly in the brain with severe strokes, in the lungs with what are called pulmonary emboli that lower oxygen levels further, the legs with deep venous thrombosis, pain and swelling in the legs, and the heart with heart attacks, congestive heart failure. The highest risk population, interestingly, is premenopausal women under age 50. So if you're a female and you're under age 50, don't get the Johnson & Johnson vaccine. It is contraindicated for you. Even though it's one and done, it may be one and permanently done. So even though the risk is less than 1 in 100,000, it's really not worth the risk with 2 excellent vaccines available as alternatives without that side effect. Next slide. So even Pfizer and Moderna now have a possible rare complication, and that's myocarditis. That's inflammation of heart muscle. Most documented cases of this have been asymptomatic. However, there have been cases where symptoms occur that have been chest pain, shortness of breath, swelling in the feet, fatigue, dizziness, even heart arrhythmias, fainting spells. Again, this is very, very, very rare. We're talking less than 1 in a million. And it's even unclear whether it's vaccine related. There's, of course, a baseline rate of myocarditis in the population. It's caused by viruses and autoimmune reactions to various other things. So this isn't even clearly a vaccine-related illness. The big concern is that with young people being vaccinated, that young athletes could have asymptomatic myocarditis, and that would, of course, put them at risk for sudden death during athletic events, which would be tragic. So this is being looked into very quickly and vigorously right now. There are studies being done and investigations into whether this is actually a vaccine reaction. My guess is that it is not. People have car accidents after vaccinations too. They're not vaccine related. Rare things happen even to vaccinated people. All right, moving on. Next slide. The new normal that the CDC has presented us with. Vaccinated people can now intermingle and socialize with each other without masking or social distancing after they're fully vaccinated. And what's fully vaccinated? That's at least 2 weeks after the last dose of your vaccination. So after your first dose of vaccination, about 2 weeks later, your odds of being protected are about 50%. 3 to 4 weeks later, your odds of being protected are about 75%. 2 weeks after the second vaccination, your odds of being protected go up to 95% or greater. With the Johnson & Johnson vaccine, the same percentages apply as just after the single dose. So if you're in a high risk group if you're in a high risk group that we mentioned earlier, if you're elderly, if you have diabetes, heart disease, lung disease, any kind of immune suppression or cancer, then you should probably consider wearing a mask even if you're vaccinated, especially if you're likely to be around unvaccinated people. If you're unvaccinated, you should continue to mask and social distance. Don't spread your virus to those who are vulnerable and vaccinated. And remember, the vaccine is not 100% effective, so vaccination decreases our odds. It doesn't guarantee 100% that we're going to get, that we're not going to get COVID-19. In fact, there have been 10,000 cases now, reported over 10,000 cases of breakthrough infections in people who have been vaccinated. Most of these have been from variant viruses, in other words, new mutations. What should business people do? Well, number one, you have to rely on local laws, ordinances, and guidelines. But I think mostly at this point, it's a matter of personal choice. If it were me, I would certainly encourage people to continue to wear a mask if they're in a high-risk group, if they feel comfortable after being fully vaccinated. It would be fine to go unmasked. Personally, I continue to wear a mask in grocery stores and convenience stores, gas stations, and at work, even though I've been fully vaccinated for 5 months now. All right, next slide. And we mentioned those variant viruses. So while we're unmasking and going about our business, we're seeing more and more variants. We see in this these regions of the US, the light orange or brown represents the original virus variant. And you can see in some regions, especially in the Northeast, new variants are causing almost up to 50% of illness. And they're causing almost all of the breakthrough illnesses in vaccinated people. The good news is that only the South African variant has shown definite resistance to vaccine-induced immunity. The Brazilian variant is showing some trend toward that. The variants from India, the UK, and California are still neutralized by the current vaccine immune response. So far so good, but things are changing. Pfizer and Moderna are feverishly working on booster vaccines to include some of the emerging variants. So what is the future going to look like? Next slide. So the question will be if we'll have another epidemic or pandemic, but when. It will happen within our lifetime, most likely. It's just a matter of time. The mRNA vaccines that were produced for COVID-19 are going to become the standard for vaccination for a couple of reasons. One, they're much more cost-effective to produce and much more efficiently produced, much more agile as far as changing them as the epidemiology of viral infections change. You see in less than a year, we went from lab to clinical trials for the COVID vaccines, and that's because the machinery for sequencing coronaviruses was revved up way back in 2003 when SARS hit. So that turned out to be fortuitous that epidemic occurred. It certainly helped us quell this pandemic much more quickly than would have happened otherwise. Also, new antiviral medications are going to be coming out. There's already a nasal spray that's being tested that one can use to coat the ACE2 and TMPRSS2 proteins in the nasal passages and upper airway to prevent viral attachment and prevent infection. And there are similar designer drugs, so to speak, genetic designer drugs that are being looked at. Most interestingly is vaccination that's being looked at on the spike protein. The upper part of the spike that actually binds to the ACE2 changes from coronavirus to coronavirus and within coronaviruses quite rapidly. But the stalk portion that connects to the virus itself is fairly well preserved across all coronaviruses. So the next goal for a coronavirus vaccine is to find a vaccine that attacks the stalk protein, which could even protect us from the common cold. The next pandemic, what's it going to look like? Well, we don't know. If we roll the dice for a 10% to 35% mortality rate, we could have much more death and disease on our hands. But I believe that fewer people will die for a couple of reasons. One, the new drugs coming out. Two, we're trained now in responding to a pandemic. I think the combined government and private sector response served us well this time. And three, the new vaccinations are going to be available much more quickly than even the COVID-19 vaccination was available. So even though the outlook for preventing another pandemic is grim, the outlook for that's all I have. Were there any questions that anyone wished to ask that I may or may not be able to answer?
I am going to stop sharing our screens. Thank you so much for joining us. We do have a few questions that have come in, so we will take those. The first question is, so for the vaccine, how long do the vaccines last? So is this we're one and done, or is this like the flu vaccine where it's an annual vaccine that folks will need to be getting?
Bottom line is we don't know, but probably it's going to be more like the flu vaccine as mutations occur, new variants emerge, new mRNA vaccines will be produced. I think the adenovirus vaccines are probably going to fall by the wayside because of the severe reactions, but we'll see. Time will tell. But yes, there are definitely going to be boosters, and how frequently we need the boosters will probably depend upon how rapidly the viruses mutate.
Thank you. Just a reminder, if folks do have any questions, please drop those either in the comment box on Facebook or in the chat box on the Zoom. So another question that came in right now, if you are vaccinated, fully vaccinated, I should say, fully vaccinated, there are certain instances where you still need to wear a mask, such as medical facilities, public transportation, those types of things. Will medical facilities ever go back to no mask? That is something that has been brought up before in other conversations. But do you think that's something that medical facilities will ever just kind of go back to the no masking policy at all?
I think we'll go back to no masking for patients without symptoms. I think personally, when I see a patient with respiratory symptoms or GI symptoms, I'm going to mask. I think that's common sense. If you have somebody who's asymptomatic, seeing it for blood pressure or diabetes or thyroid, I think in the future it's going to make sense to not have to wear a mask, for it not to be mandatory. But anybody with respiratory symptoms or GI symptoms, I think it would be wise to continue masking. It works. It's been shown to work. And look at the incidence of influenza this year. Influenza A and influenza B, almost non-existent. Why? Because of social distancing, mitigation measures, masking. So it makes sense. But I would use it selectively.
Great, thank you. The next question that came in, do you have any advice for business owners if they have employees who might be hesitant to get the vaccine?
Well, we can't force them. We can't force them. Even though legally I've read that courts have said that's okay. I would strongly encourage them to. I would attempt to educate them, maybe share some of the data that we looked at today, which, by the way, I'm happy to share those slides. They're not copyrighted or proprietary, so I'm happy to share those. I mean, the purpose is to educate people and have them be more comfortable and approach the pandemic more wisely. So please share them. But I think education and encouragement are key, as opposed to brute force, so to speak, saying you can't come into work unless you're vaccinated.
Thank you. And that was one of the questions actually that came up is, can we share the slides? And so for folks who are interested, if you registered for today through the Zoom, I'll send those out afterwards. But if you want to drop your email in the chat box on Zoom, I can get those to you specifically, Terry, speaking of you. So thank you, Dr. Garner, for allowing us to share those.
No problem.
For our businesses, Friday marks kind of the date that we as Illinois will transition from the bridge phase into phase 5. So with that, my understanding is that kind of gets rid of our capacity limitations on a lot of our different venues. And so in offices and restaurants and those types of things. And so as the state enters into phase 5 on Friday, does that mean that businesses should scrap all social distancing and masking requirements and immediately go back to normal? Or it sounds like you are still recommending, using some social distance and masking as appropriate.
I think businesses should encourage unvaccinated people to continue masking. I think vaccinated people should use common sense. If they have a high risk underlying condition, they should continue masking in public. If not, then they can go mask free. And of course, you have to trust those people who are unmasked or vaccinated. And we know that not everybody who is going to go without a mask has been vaccinated, but that's real life. So I would, again, wisdom and selective masking are appropriate. Common courtesy amongst individuals, caring about our fellow human beings enough to protect them from our own potentially infectious secretions is important. And I would hope that most people, I know all people aren't going to care, but I hope that most people realize that this is real and there's science behind it, and it's a catastrophic illness that can be prevented. And having seen it firsthand too many times, I can guarantee you that nobody wants to get this.
So Dr. Garner, I do have one other question that came in. So as we move forward and we try to educate and encourage employees, as you suggest, what can we tell them about the vaccine safety? So that's a big question that I know folks have had. Some of the pushback is the vaccines were developed very quickly. Folks are questioning, just kind of the safety of those vaccines. Are there things that our employers should note about that, or are there other resources out there that we can direct our employers to?
There's the CDC website, the Illinois Department of Public Health website, IDPH. The vaccines are very safe. It's much safer than taking a risk of getting COVID. These vaccines are safer than the polio vaccines that came out in the 50s. They were developed rapidly because the technology was sitting there waiting to be utilized, so to speak. And the technology that we have now can produce RNA very quickly, can sequence and produce RNA very quickly. The vaccines went through the same process. I'll go back. The technology has been out there for over 20 years. It was there when SARS and MERS were around, and that's sort of primed the pump to get things ready for 2019, and that's why we're able to respond so quickly. The science was there, waiting and ready, poised. As far as safety, again, reactions have been rare. These vaccines are safer than any of the attenuated virus vaccines that have been used for years, even in children. The only vaccine I have any qualms about is the adenovirus vaccine, Johnson & Johnson vaccine. Personally, I wouldn't get that one. Why take the risk when there are two others that have only minor side effects noted? The myocarditis issue is probably going to go away. I suspect that is just a little random blip on the radar and not really vaccine associated. And most people who have that have been asymptomatic anyway, no symptoms whatsoever. So, if they won't get vaccinated for themselves, I would encourage them to get vaccinated for friends and family members who might be at risk, for grandma or aunt or uncle. or any family member with a chronic condition that puts them at risk.
Thank you. With the vaccination safety, right now, are any of the vaccinations, I know FDA approval has been a big thing that's come up in conversation, and I know a few of them were working towards FDA approval. Do you have any updates on that piece of the vaccination process?
I know Pfizer is close, and we'll go back, the emergency use authorization. These vaccines went through the same process that regular authorization would require for a vaccination. The only difference was it was truncated. Once the studies really reached statistical significance as far as preventing illness, and there were no documented severe reactions, the vaccines were given emergency use authorization. The first phases of vaccine production were overseen by independent panels and medical groups, and they went through the same process as any other vaccine has ever gone through. Again, the machinery was primed and ready to go, and that's why they were able to get from lab bench to clinical trials so quickly. The clinical trials, the initial clinical trials had the same length as the clinical trials for any other vaccine. In fact, they actually delayed release. I found this out by in a Zoom meeting with several hundred physicians and Anthony Fauci and a few other high-ranking individuals, but they actually prolonged the last phase of the study a little bit in order to gain enough minorities in the study group to make certain that the vaccine was safe in minorities. People of all shades of brown were included in the studies and had statistically significant safety proven for all races except Asian and Pacific Islanders. That's about the only group that didn't reach statistical significance. So again, as soon as the studies in the last phases reach statistical significance, instead of making them go on for a year or more as usual, the FDA decided that with thousands of people dying every day, it was time to release the vaccine, that the benefit far exceeded the risk. And the decision has proved to be wise. Deaths have been prevented. About half of the adult population has been vaccinated, and the virus is being contained.
Thank you. And Dr. Garner, I want to thank you so much for joining us today and for this very informative session. I actually learned a lot myself, so thank you so much for joining us today. Before we conclude for today's presentation, is there any final thoughts that you want for our business community to be aware of? So the Chamber represents over 800 local businesses here in McLean County. Is there anything that you just want to leave final thoughts with them today about the vaccine, the vision, and the virus?
Do what you can to encourage people to get vaccinated. Encourage people to proceed wisely and to protect others. Be courteous and love your fellow human being by protecting them.
Thank you so much. Again, I want to thank you for taking the time today to present to the McLean County Chamber of Commerce. The Chamber would once again like to just recognize our June Video Resource Library, Health Alliance. Make sure to check out our video resource library at mcleanCOchamber.org. This session today has been recorded. And so we will be putting up the video out on our video resource library shortly. It was also streamed to our Facebook group today as well. So this concludes our Member Ed for June 9th. I want to thank everyone for joining us today and have a wonderful afternoon.
Thank you.